Welcome back, colleagues, to our last but not least session, where our young colleagues will be presenting their novel work. Young colleagues, the future of our specialty. So delighted. Thank you all for submitting your work for consideration. It was not an easy decision, and I thank the faculty for helping in selecting the 20 best abstracts that will be published in the new journal, the International Journal of Cardiology, Congenital Heart Disease. And then we have the 3 finalists to present their work. One of them is a recorded presentation. I would appreciate if they took 10 minutes to present, and then we'll have a few minutes of questions from the audience. The first finalist or winner, if you wish, will have a complimentary place at the 2021 meeting in Seville next year. And the second and third will have signed copies of 2 of the textbooks that I have credited with colleagues. So this is the last textbook going through the 4th edition. And this is another volume, smaller in size, but equally important, on pregnancy and heart disease, with my dear colleague and friend, Professor Steer. So with no further delay, I would like to invite the first presenter, Yuan He, from the Beijing Ansem Hospital, Capital Medical University, Beijing, China, and very good to see you again in person, albeit from a distance, who is going to present their experience on close and treat strategy in adult congenital heart disease related pulmonary arterial hypertension. Dr. He, thank you.
Okay. Thank you, Professor, thanks for your introduction. And good afternoon, dear professors and fellows. The topic I share today is close treat strategy in adult congenital heart disease related pulmonary arterial hypertension. Data from Europe showed PAH after defined closure is considered having worse prognosis than unrepaired device and Eisenmenger syndromes in both adults and children. Therefore, criteria for operability is relatively strict. However, in China, many patients with CHD came to hospital in their adulthood and missing the best time for defect correction for developing pulmonary vascular disease. In the recent decades, there's substantial progress and availability of medications to treat pulmonary arterial hypertension, and clinicians are now reconsidering defect closure for congenital heart disease that were previously considered to be contraindicated or high risk due to coexisting PAH. And here comes the close treat strategy. Here's the basic process. First, the patients will receive right heart catheterization and other examinations to determine whether defect closure could be performed. And if the indicator is higher than the suggested criteria, but not up to Eisenmenger syndrome, the patients will start target therapy of PAH-specific medications and receive regular reassessments. And the defect could be closed eventually if the symptoms and the hemodynamics improved. And close follow-up and continuous targeted therapy are necessary to determine when to stop the medications. However, there's lack of evidence to evaluate the safety and the effectiveness of this close treat strategy. And our study provides a retrospective evaluation of this strategy. This is a single-center retrospective study, and the inclusion criteria is age higher than 18 years old, and all patients were confirmed with pulmonary arterial hypertension associated with unrepaired congenital heart disease by RHC, and all patients received targeted therapy of PAH-specific medications prior to defect closure. And subjects were excluded for complex CHD lesions and additional PAH risk factors such as connective tissue disease or portal hypertension. Our study included 23 patients, and the mean age was 30.9 years old, and female accounted for about 74%, and pre-tricuspid lesions, which is ASD, accounted for 60.9%. And in our study, 26% of patients had severe symptoms with the WHO function class level 3 to 4. And the hemodynamic parameters shows our patients had severe PAH. The duration of medication prior to defect closure is about 11 months. And among these patients, about 48% patients receive double medications, and 52% of the patients receive single medications. And after the defect closure, our patients continued targeted therapy, and 58% patients received single medication, and 52% received double medications. At initial evaluation, our patients were symptomatic, and after a period of targeted therapy, no patients got deteriorated clinically, and the 6 patients with WHO function class 3 to 4 were improved to WHO function class 2, and 21 patients underwent transcatheter defect closure, and 2 patients required surgical repair, and no patients had procedure-related adverse events after defect closure. And the mean duration of follow-up is about 31 months. No patients died. And besides, 1 patient had adverse event, which is right heart failure. BNP elevated significantly, and the WHO function class is level 3. The others maintain a WHO function class level 1 to 2. And after the therapy and prior to defect closure, the patients got improved in mean PAP, PVR, and pulmonary to systemic resistance ratio. And at the follow-up, 22 patients received repeated RHC, and 6 patients reached normal PAPs. And the rest of the patients had persistent PAH after defect closure. However, we can see their hemodynamic parameters got improved at the follow-up. It is a remarkable fact that 17 patients in our study had PVR higher than 5 U units when get closed. And besides the one who had adverse events, 16 of them got elevated in PVR, got decreased in the PVR and mean PAP in the follow-up. And 96% of patients were in low risk at the follow-up. However, there was 1 patient had right heart failure, and here's the detailed data of this patient. So there have been several studies about treat to close strategy, and the results they had were as encouraging as our results. However, the patients in our study had the highest PVR when get defect closed. The current indicators, the current guidelines show that when PVR higher than 5 U units, the defect closure is contraindicated. However, our results showed with targeted medications, most of the patients were in low risk, even coexisting persistent PAH after defect closure, and the hemodynamics could be improved. Even patients were considered inoperable when get closed. So there are some limits for our research. The first one is our study is a small sample, single center retrospective study. So there is selection bias and some data are unavailable. And the duration of follow-up is relatively short, and the long-term effect is still uncertain. And the third is the selection of PAH-specific medications is different between patients because of different financial situations of patients, and some patients were referred from outside hospitals. In conclusion, our results show that treat-close-treat strategy could be an effective therapeutic strategy for ASHD-PAH, and it is possible to expand the criteria for defect closure with PAH-specific medications and close follow-up. However, larger and longer-term studies are required to provide additional insights to optimize the clinical outcomes in these patients. And thanks for your attention.
Thank you very much, Dr. He. Amazing data and wonderful presentation. I don't see many questions from the floor at the moment.
Okay.
May I ask you, please, one or two clarification questions?
Okay.
The patients who underwent defect closure, many of them stayed on PAH therapies, or
Yeah.
are you able to come off them? On the repeat hemodynamic data that you show, were the patients still on advanced therapy for PAH?
Yes.
Were. And what is the mean time or median time from the procedure, defect closure, to your repeat hemodynamic assessment? Is that in months, or what was the follow-up time?
3 to 6 months.
3 to 6 months. And you did mention that in your, kind of limitations of the study section. Was clearly, and I'm sure that's what you're doing. You're going to continue to follow up these patients closely.
Yeah.
They're on advanced therapy, and then you've shown reduction in pH or in pulmonary arterial pressures, but some of them still have underlying pulmonary vascular disease.
Yes.
Very interesting. And was cyanosis, profound cyanosis, something that would make you concerned about closing defects? Did you use that in your selection criteria? Probably was. They're not truly isomonkey patients, these.
Yeah.
With left-right shunting.
There's only, as you can see in my presentation, one patient had adverse events at the follow-up. Actually, there's controversial about the operation for this patient because, as you can see, the PVR is about 11 units when he got close. So, the reason I want to show the data of this patient to you because you can't ask every doctor in our center to how to say to observe one criteria because so there's the current situation in our medical center.
Yeah, of course, and there's a lot to learn from you because you have a different population, as Professor Gu clearly indicated. Got a large number, obviously a large country in population terms, and you've got a large number of isomonkey patients and also late presentation. So thank you very much, Dr. He. This is very interesting. I don't see any questions, so maybe what I would suggest is that we go on to the next recorded presentation for